co-host. I think you only will have to.
Okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah. Wonderful. Co-host. I think you only will have to.
Okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah. Wonderful. Co-host. I think you only will have to.
Okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah. Wonderful. Co-host. I think you only will have to.
Okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah. Wonderful. Co-host. I think you only will have to.
Okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah.
What's the echo?
No, echo is probably on my computer.
Wonderful.
It's just looping. Just one sec.
Okay.
I usually do this
Co-host.
before.
I think you only will
So,
have to.
okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah.
What's the echo?
No, echo is probably on my computer.
Wonderful.
It's
Echo.
just looping. Just one sec.
Okay.
I usually do this
Co-host. I
before.
think you only will
So,
have to.
okay, just hold on. I'm just.
No problem. No problem. You are live streaming it. Got it. Yeah.
What's the echo?
No, echo is probably on.
Hello. 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 Am I audible?
Yes, Dasmit, you are.
Okay. I just wanted to check this.
We are trying to make you co-host. So
Yeah. No problem.
you and Shama.
Rajiv, I have sent you a WhatsApp link of a YouTube link. Maybe that's something that you can.
Okay, I will share it with all the Maharashtra chapter people. Thank you.
Okay.
Wonderful.
Okay. Dasmit is co-host as well.
And Shama K. Thank you.
Okay, make co-host.
I'm just checking my share screen. So just give me a moment.
What I will do, Rajiv, is I'll try to make you host. Then you should be able to do everything then. Yeah.
No problem.
So I'll make you host, but I will lose control. So just if you are okay, then I will log off. I'm making you host now.
Well, then I suggest that you make Dasmit the host because the meeting is hosted by Pune this time.
Oh, okay. Okay.
So is it Dasmit or Shama who wants to hold the fort? Shama?
Shama, I think so.
So if you can make Shama, are you comfortable with being a host?
I'm not used to this, but then I can try.
No. The try.
Otherwise,
Yes, so what we can do is then you make me the host. I'll stay in command.
Okay, I can remain as co-host in case anything needs to.
Yeah.
Basically, the only thing you need to really do is mute everyone. Okay, can you see my screen?
Yes, we can.
Yeah.
Okay.
So Rajiv, I have made you a host.
Wonderful. Thank you.
You're okay?
Wonderful. Yes, I'm okay.
So I'll just mute and just stay online for 10 minutes. If things are okay, then I'll probably log off. Yeah.
Wonderful. Wonderful. And if
Thank
we
you.
need to disturb you, I'll call you up.
Yeah, sure.
Thank you so much, Sanjay,
Thanks.
for all the.
No problem. No problem. Bye.
Okay. Cheers.
Okay, we can see your screen, Shama.
So can you also allow me screen sharing?
Yeah, you'll have to unshare now. Shama, you have to unshare your screen. Great. So, Abhilasha and Ashlesha, you can also just give it a try.
So it says the host disabled participant screen sharing.
Raju
Sorry,
sir,
Ashlesha, what did you say?
It says the host disabled participant screen sharing.
You'll have to make them also co-host
no
Or
sir,
give-
you have to allow the screen share.
or allow screen share.
Allow the screen share for participants.
Yeah.
So
Not
I
all.
have to allow. Is
Yeah,
it? I am
yes,
the
yeah,
host
yeah.
now.
Yes sir.
Yes.
So edit.
You have to go in the screen share,
Yeah,
sir.
multiple participants.
Yeah, multiple,
can,
yeah.
I've done that.
Yes, sir.
Okay. Yeah.
Okay, I'm going to mute all. So only the person who wants to speak can then unmute themselves.
So can you see the screen?
Yes, we can, Ashlesha.
Okay. Thank you so much.
I'm muting all because there are a lot of mics which are on. Please unmute and then restart. Yeah, Abhilasha, just unmute and check. You're still muted. Yeah,
Yes, yes. Okay, I have muted.
great, great. Ashlesha, can you do the same? Just check your.
Yes, sir. Can you hear me?
Great. Yeah. Okay, fine. So I think we are all set. Our screen share is done. Muting, unmuting is done. In between, if at all we're finding too many people making
Can
a
you see my?
noise. Yes, fetus in P2, we can see that.
Yes, sir.
You'll have to
No,
unshare.
no. Can you
Okay.
see this now?
I should stop sharing.
No, you'll have to stop sharing. That's the other thing you have to remember.
All right.
Once you're sharing, you have to unshare so that somebody else can then share.
Okay, sir.
Okay, and it goes back to the
Okay.
home page
Yeah,
only
it's
then.
also giving it.
Yeah, Abhilasha has also come. We can see your screen, Abhilasha.
Now you can see my screen.
Yes, very much.
I can see you. I mean, okay. Now can you see my screen?
We can see Abhilasha's screen.
Okay.
Actually, that's what I'm
Yes,
presuming.
yes.
Yeah, it is Abhilasha's screen. So just
Wonderful.
Yeah, I
unshare
mean,
it.
my name is there.
Yes.
Uh,
So now you'll have to.
yes.
Great. Fine. So I think we are.
Is it on now?
Yeah.
Yes.
Okay. Now keep a track
So,
of this.
can I just come to know one thing? So when I'm sharing my screen, I can't go back to the window and see the participants or
No.
interact. I will have to keep looking at my screen at that time.
Yes.
Okay.
Yeah.
Sir, I'll just check whether my presentation is opening.
You have option to see the participants also. In the view, when you are sharing the screen, you can change the view, so you can see some participants.
Yeah. That in the top right corner, no? That you
Yeah.
have something called a view. In that you can change.
Dasmit, is it 9 o'clock in your watch?
Just about.
So shall we begin?
Yeah, we have 31 out of 140.
Yeah, but then I think, let's stick to time because we have given time of 9 o'clock. I don't mind waiting for a minute or two. But
Yeah,
then
just
I
a
think we
minute or
should
two,
start.
I think we should be okay. Shama, your presentation, you'll have to minimize and keep it ready. Okay, you open your presentation, minimize it and keep it ready. So when you share your screen, it will ask you which window is to be shared. So you just click on the presentation and it'll come up. Or you got a pirated version, then this thing comes up. It's asking for the product key. Well, hi Pranav, I just saw him sometime back.
Smith, how many cases do you have totally?
I think Shama's doing the count. I think she was telling me there are some dropouts. So finally, I don't know how many cases.
Shama, how many cases do we have?
I think she's getting her PowerPoint thing sorted out.
Okay. Okay.
Sir, actually, 8 cases are there. Out of that, 2, Dr. Jayesh Desle and Dr. Ajay Naik are not presenting. So we have 6 cases.
6 cases. That should be good enough for hour and a bit. Yeah.
Yeah.
So Dasmit, whenever you are ready, I am ready for starting. Shama, whenever you are ready.
Yes, sir.
I think
Sir, I'll let you know the sequence of presenters. First is Ashlesha, then I am presenting, then Jayesh is not there, so Dr. Dasmit Singh is presenting. Then Abhilasha has 2 cases, and then I have the last case.
Fantastic. Fantastic. So shall we start then? Because
Yes.
we are
Yeah,
well
Yeah,
past
We
please.
9
have to
o'clock.
start with Ashlesha.
Yeah.
Yeah.
So
Rajiv.
I will I welcome all of you for these Maharashtra chapter IAPS meetings. I think we are going brilliantly, and this time we are expecting a wonderful series of cases from the Pune group. So I welcome one and all on behalf of the MC Maharashtra chapter of IAPS for this feast. Over to you, Dr. Shama, for your presentation, or Dr. Ashlesha to begin with.
Okay. So shall I start, sir?
Yes, please.
Thank you so much, sir. Good evening, everyone. I'm Dr. Ashlesha Shimpi, Assistant Professor in Department of Pediatric Surgery at the D.Y. Patil Medical College, Pune. Today, I'll be presenting a case of fetus in fetu that we had operated a few months back. So, giving an introduction, it's a rare condition. As we all know, it's present only in 1 in 5 lakh births. It has a male predominance of 2:1. There are a few proposed theories for the formation of the fetus in fetu, of which the most accepted one is abnormal embryogenesis in the monozygotic diamniotic parasitic twins. The other theory is highly differentiated teratoma leading to this with presence of vertebral bodies. It was first described by Johann Meckel, and it's because of the unequal division of the totipotent inner cell mass during the blastocyst formation. The most common site is retroperitoneum. The rest of the most commonly in the abdominal cavity. The rest sites include the thorax, rarely in the neck region, also in the pelvis. Then it is basically the parasitic twin that is incorporated into the body of the normal baby. and it is the differentiated from teratoma by presence of the vertebral column. Now coming to our case, it was a 15-month-old boy who had an abdominal mass which was diagnosed since birth, gradually progressing in size. When on presentation, the patient was malnourished and anemic. There was a 12 by 10 by 10 centimeter mixed consistency lump present in the right hypochondrium, reaching up to the right iliac fossa. We investigated the child thoroughly, of which the lab investigations and the tumor markers, that is both the beta HCG and the serum alpha fetoprotein, were all normal. X-ray abdomen erect showed calcification in the right hypochondrium. This shows the calcification here. Then we went for the ultrasound, which was again suggestive of a mass with all the 3 germ cell layer tissues present. So for confirmation, contrast enhanced CT scan was done, which was suggestive of a well-lobulated, well-differentiated, lobulated, heterogeneous, mixed density lesion in the retroperitoneum, which was measuring 12.7 by 9 by 10 centimeters. It showed mixed fat, soft tissue, and bones, suggesting of all the 3 germ cell layer presence. The lesion caused mass effect on the infrahepatic IVC, and the course of IVC was also deviated. These are the CT images. On the cross section and the surgical, we can see the presence of the amniotic sac, the bones, soft tissues, mixed consistency. We got a 3D reconstruction done. This is the lesion here, showing the bones and the soft tissue. So we went ahead with exploratory laparotomy, and the mass was excised in toto with a separate sac which was there, and it was adherent to the IVC. So we have removed the entire mass with the sac. There was a vascular pedicle from the SMA, which was just distal to the middle colic artery. The entire mask with the capsule was removed, and there was no lymph node involvement. The patient was the intraoperatively it was uneventful, and the post-op recovery was also good. This is the image showing the entire mass present from the hypochondrium, crossing the midline and reaching up to the right iliac fossa. These are the intraop images. Here we can see the IVC and the mass. The IVC was completely deviated on the opposite side, that is on the left. And here the mass is seen. A few more intra. Here we can see the pedicle attached to the SMA. And these are the intraop images. So this is the excised specimen. It was total 1080 grams with the sac and presence of all the appendages. We had sent it for the histopathological examination, which revealed that there's presence of skin, vertebral body, then cartilages, bones, sympathetic ganglia, adipose tissue, lymphoid, and male genitalia, the elements of all the 3 germ cells. Alpha fetoprotein levels were repeated post-operatively 3 months later, which came to be normal. So to discuss a few points about the fetus in fetu, the studies of genetic markers suggest that the host infant and their fetiform masses are genetically identical. Hence, it is seen usually in the monozygotic diamniotic twins. Most commonly the most common presentation is in infancy and up till the 18 months of age. The site is retroperitoneum, and it causes, usually it's a single mass. However, very rarely fetifoid elements may be seen, but it is primarily causing mass effect. That is how it is diagnosed by the parents. How do we differentiate the fetus in fetu from a teratoma? There are few points. The most important is presence of vertebra, because the it is arising from the notochord. Hence, the vertebral body presence is the most important differentiating character from the teratoma. The mass is enclosed within a distinct sac, which can also be present in teratoma. It is partially or completely covered by skin. Grossly recognizable anatomical features are also present, and it is attached to host by a pedicle containing a few relatively large blood vessels. So imaging is the most important investigation that is to be done, that is CT or MRI. Retroperitoneal teratoma and the retroperitoneal fetus in fetu, differentiation preoperatively is very important. because there are chances of malignancy, that is 10% in retroperitoneal teratoma. However, fetus in fetu, the chances of malignancy are absent. In fact, there's only one reported case. It is basically derived from the totipotent inner cell mass, while the teratomas arise from the pluripotent cells. Hence, the vertebral bodies are present. And although it is benign, complete excision is the treatment of choice, because there is possibility of malignant recurrence if any of the tissue is left behind, not excised completely. So in the conclusion, it is basically the diagnosis preoperatively, because with the high degree of suspicion that we have to keep in mind. Then the treatment is complete excision. A future research should be made to establish the true nature of the fetus in fetu, and to determine the possible association between the fetus in fetu and teratoma. Also, they are benign lesions, but still follow-up is advised with the help of the tumor markers. Thank you so much.
Very nice presentation, Ashlesha.
Thank you, sir.
Yeah. Is there any question on the chat box? There is none.
Okay.
Okay.
Yeah.
So shall we move on to the next presenter? Shama, are you ready with your?
Yes, sir.
Okay.
Abhilasha, can you stop the screen sharing, please?
Ma'am, I'm done.
Yeah. Okay. So am I audible and my screen is visible to all?
Yes, Shama, you are
Yeah.
audible and your screen is seen in full.
Thank you. Thank you, sir. So good evening, everyone. So today I'll be presenting a case of seco-uretrocele with bladder outlet obstruction and a neurogenic bladder. So this child was a full-term female child who presented to me on day 7 of life with history of fever and was admitted in our NICU as a case of late onset sepsis. Her antenatal scan at 35 weeks of pregnancy was suggestive of bilateral hydronephrosis, query ovarian cyst or a rectal pouch, but there was no oligohydramnios or polyhydramnios. Since the baby passed urine on day 1 of life, and as usual, since the baby passed urine, the parents were told that the child is all right, and so no investigation was done till 7th day of life, in spite of having a bilateral hydrouretronephrosis. So on examination, this child had a flat nasal bridge, low set ears, a broad philtrum, a sacral dimple was present, and the coccyx was probably absent. There was a mucosal cleft present from the posterior fourche to the anus, though the anus was normal and systemic examination was normal. A septic workup was done, and the blood culture showed Burkholderia capacea species, and the CSF was normal, though there was a contaminant, probably Pseudomonas. Urine routine and urine culture was normal, and X-ray chest, neurosonogram, and USG spine was normal. So this child was started on IV antibiotics, and the serum creatinine on day 7 of life when she was admitted was 0.25. Now, since this child had a antenatally detected bilateral hydronephrosis, we repeated the scan in our hospital, and then the USG abdomen here showed bilateral hydrouretronephrosis with dilated tortuous bilateral ureters, and there was bilateral increased cortical echogenicity. Here you can see this is the right kidney with dilatation of the calyces as well as the ureter, and the left kidney was also grossly dilated with hydrouretronephrosis, and the left kidney was little smaller in size than the right side. So a USG abdomen was done. In the USG abdomen, again, the urinary bladder was showing a thick wall cystic structure. And this thick wall structure was almost 3 mm in thickness, and size of mentioned was around 14 mm. Near the left VUJ, probably a uretrocele. So considering it to be a case of uretrocele with probably a bladder with probably a bladder outlet obstruction, I planned for her MCU. So since in-house fluoroscopy was not available, this patient was sent for MCU under fluoroscopy outside, where we noticed that there was a trabeculated bladder. Here you can see in this view, there is a trabeculated bladder. But then the radiologist said there was again a contrast filled pouch posterior to the bladder, which was probably a diverticulum. But then they found that there was some communication present of this bladder with the rectum. So they had passed some dye through the anus, and they found that there was a communication, probably a rectovesical fistula, though they have mentioned here as a rectovaginal fistula. So probably a high ARM. This was reported in her MCU and a dye study picture. Since this child had a sacral dimple and there was a mucosal cleft, plus the MCU and the dye study was suggestive of query ARM, I thought to get her MRI pelvis done, since the child was not having any urosepsis and there was bilateral hydrouretronephrosis. So before planning anything, I thought to get the MRI pelvis done of this child. And this MRI was suggestive of a large uretrocele around 20 to 26 millimeter into size, which was extending into the bladder neck. And in the MRI, they found that the left ureter was probably extending into the bladder neck and opening into the bladder neck. But there was no definitive demonstrable communication between the rectum and the vagina. And on the MRI, they found that the coccyx was absent. So probably it was a case of caudal regression syndrome. Here in this MRI picture, you can see a large uretrocele, which is extending into the bladder, and bilateral tortuous ureters. And again, you can see here the uretrocele, which is communicating with the left ureter. So I planned in this patient, I planned to do a on table MCU and repeat a dye study on table and proceed with cystoscopy and incision of the uretrocele. I did a on table MCU. Here you can see the bladder looked trabeculated, but the size looked okay. There was no reflux. And when the dye was passed through the rectum, there was no communication with the bladder. So I planned for cystoscopy and incision of uretrocele, proceeded with that. There was a short patulous urethra on cystoscopy. The bladder was highly trabeculated with multiple diverticulae. The right ureteric orifice was not visualized and there was a diverticulum near it. So this is the cystoscopy picture I have taken, where there is a right ureteric orifice looked okay, but there was a diverticulum lateral to it. And the left ureteric orifice was not visualized, but there was a large thick walled cystic structure which was noticed inside the bladder, which was extending into the bladder neck also. I was not able to take the video here, so I'm just putting the pictures. This is again the large thick walled cystic structure, a uretrocele. So I did the incision with the it was actually very thick walled, so the incision was really difficult in this case. I had done multiple punctures, tried to connect it, but this was the this I tried with the Bugby. So probably I did multiple punctures, but then I was not able to get a proper incision in this case. So finally, I kept a catheter for continuous drainage to check whether the bilateral hydrouretronephrosis decreases with continuous drainage. And so on day 7, post this cystoscopic incision of the uretrocele, I repeated the sonography, but then again there was a bilateral hydrouretronephrosis and echogenic kidneys. They said the uretrocele is collapsed and now it is 8 millimeter, but then this uretrocele wall, you can see here in the ultrasound, it was quite thick walled uretrocele. So the baby was discharged after giving the antibiotic course, which was for her sepsis. Blood culture was positive. So after giving the antibiotic course, this child was discharged and kept on continuous antibiotic prophylaxis. Since the urine culture and urine routine was normal and there was no fever episode, this child was told to keep a close follow-up, and the creatinine on discharge was 0.47. So this, the parents brought the child 1 week post discharge. The baby was well, febrile. She was passing urine well. But then on day 7 after discharge, when I repeated her creatinine, the creatinine has shot up to 0.73. Urine routine and culture was sent, and this time the urine routine was showing plenty of pus cells, and even the culture was positive, and it was sensitive only to cholesterol. So on day 10 of life, the creatinine was 0.7 and there was hyperkalemia, hyponatremia, and the chloride level was low. So she was admitted for urosepsis again in the NICU. So this time, since the child was already 1 month of age with bilateral hydrouretronephrosis without a reflux, I thought to get an EC scan done to check whether the kidneys, whether the ureters are obstructed or not. So on the EC scan, it showed a smaller, satisfactorily functioning hydrouretronephrotic, non-obstructed left kidney with a function of 40%. but a normal functioning hydrouretronephrotic delayed clearing non-obstructed right kidney. A DMSA was also done at this age, which showed a smaller left kidney again with a function of 40%, but there were no evidence of scars on both the sides, and the right kidney function was normal. USG was repeated after admission second time, and it again showed bilateral echogenic kidneys with collapsed uretrosil and persistent of hydrouretronephrosis. So finally, I thought to do a vesicostomy because this child needed some drainage procedure, and along with that, the partial excision of the uretrosil was done. So here you can see this was the thick walled uretrosil. It was a large cystic structure which was present in the bladder, but quite thick walled, which was extending through the bladder neck. So I excised this uretrosil partially, and then I passed the catheter, but the catheter was coming out directly through the urethra. So on follow-up, now the creatinine came down to 0.57, but since again the USG was showing persistent bilateral hydrouretronephrosis, so I thought after drainage we have to wait for some time and then see whether the hydrouretronephrosis decreases. I kept this child on follow-up. The child was growing well and the vesicostomy was functioning well. No episodes of UTI after that. But at 10 months of age, this patient developed a vesicostomy prolapse. This I reduced in the emergency room. Post this episode of prolapse and reduction, the child again developed a febrile UTI and was again admitted for antibiotics since the child was not sensitive to oral antibiotics. This time the creatinine repeated was 0.36. This is the picture of the vesicostomy which had prolapsed at 10 months of age. And since this child had absent coccyx and wanted to rule out, wanted to see the spine, this MRI spine was done, which showed a lower sacral spina bifida with complete lumbarization of S1 vertebra and partial lumbarization of S2 vertebra. The conus tip was noted at the L3 level with fatty phylum terminal, but there was no obvious tethering of the cord. A neurosurgery opinion was taken, and then they said presently nothing to be done because there is no tethering as such. So between 1 year to 2 years of age, this child continued to grow well. The vesicostomy was functioning well. She was passing intermittently urine per urethral also. Creatinine was in the range of 0.5. USG this time after 1 year of age started showing mild regression of the hydrouretronephrosis. There was just mild hydronephrosis remaining. Urine routine and culture, most of the times her urine routine and culture used to be positive. I thought because of the prolapse and they were it used to get reduced, but sometimes the parents were reducing. Maybe she was having a symptomatic bacteriuria. This child had intermittent constipation but used to be well with suppository, and she was well on Dufalac. So now in August 2021, when she was around almost 2 years of age, I thought I did a repeat ultrasound. That time the right kidney appeared normal and mildly prominent right renal pelvis was there, and left kidney appeared normal. Bladder could not be assessed as there was a vesicostomy status. Since persistently till 2 years of age, each time there was a bilateral hydrouretronephrosis, I got the MRU done to check whether there is really a hydronephrosis, and plus for the further plan, because I wanted to close the vesicostomy, but urodynamic study was not possible, to try to get the MRU done, which was done at more than 2 years of age. On the MRU, there was no evidence of hydronephrosis or hydroureter on either side, but there were small septal projections which were seen along the posterior wall of the urinary bladder on either side of the midline, which were converging near the bladder neck. These were probably the remnants of the excised uretrosil, and there was no obvious evidence of uretrosil as it was already excised. Here you can see the bladder capacity looked okay, though she had a vesicostomy. She was intermittently passing urine per urethral also, so it was maybe partly functioning. Here, these are the septal projections, and here you can note a small diverticulum-like structure which is present posterior to the bladder. So now a DMSA scan was done at 2 years, almost 2.5 years of age, before planning for closure of the vesicostomy. Now the split function, left kidney function had gone down a bit. It was showing 34% function, and now there were evidence of scars present on the left side, while the right renal tubular function was normal. So I planned her surgery in December this last year, 3 months back. And before doing anything, I thought again to repeat a MCU to check whether the bladder capacity is good, because I had planned for a left ureteric reimplantation, considering the function to be dropping down and mention of a left ectopic ureter. So MCU was done here. The bladder looked okay. There was no reflux. So I proceeded with left ureteric reimplantation with the vesicostomy closure. So this is the operative picture. You can see, like in the MRI, they had said the septal projection. The same thing I found out on the intravesically, and the left ureteric orifice was not visualized. I was able to catheterize the right ureteric orifice. I traced the left ureter extravesically, and then I was able to find the left ureteric orifice internally also, but it was quite small, not able to, the catheter was not going in. But then with the ureteric catheter, I was able to catheterize it, and then left ureteric reimplantation Cohen's type was done. And this is the post-op picture of her. So now in the post-op follow-up, this child is doing well. Otherwise, she never had a episode of UTI. I mean, never had an episode of fever or anything. But then her urine routine is persistently showing bacteriuria. Intermittently, she passes turbid urine, which is resistant to all oral antibiotics. The creatinine is 0.5. So I repeated an ultrasound considering whether it is presenting like a neurogenic bladder because of the intrauterine bladder outlet obstruction. So the USG now again shows a bilateral hydrouretronephrosis, and they said the post-void residue is present. I wanted to get her MCU done now. So, and since urine was turbid and resistant to all oral antibiotics, I admitted her for giving injectable antibiotics, and just wanted to do a continuous catheter drainage to see whether the hydronephrosis is decreasing with continuous catheter drainage. So when I repeated, so this is the ultrasound, sorry, this is the post-op ultrasound, which was done at around 2 months of age after closure of vesicostomy and ureteric reimplant. It again showed dilatation of the pelvic LSL system. So this is the MCU again done post-op, 3 months post-operatively. The bladder looked okay, but then there is a diverticulum present, which was previously present in the MRU also. The urethra is okay. The bladder is definitely little trabeculated, but then there is no bladder outlet obstruction as such. There is no reflux. After catheter drainage, where the MCU was done, I repeated the ultrasound. Now the sonologist said there is bilateral, just minimal hydrouretronephrosis. The ureters are not dilated, and normal cortical thickness is present, and corticomedullary differentiation is normal. So now I again did a EC scan just 3 days back. It is showing small subnormally functioning left kidney, and the kidney function has gone down to 26%, but there is no obstruction to both the ureters. And the DMS is also showing decrease in the function. There is evidence of scars on the left side, but no evidence of scars in the right side. So now my next plan is to do a urodynamic study, but I have a few questions because after doing all this procedure on this patient, this child is probably behaving like a neurogenic bladder. Now this neurogenic bladder is because of her bladder outlet obstruction, which was present in the intrauterine period because of the uretrocele, or is it because of the spina bifida she has? I don't have an answer to this. Will this child need a CIC? I think she needs a CIC, but this is an extremely uncooperative child. She doesn't even allow a palpation. So I don't think she is going to allow me to do a CIC. In this case, if a Mickey button in the bladder will help for the CIC and night drainage, or she should undergo a vesicostomy again, or any other procedure. I open this case for the discussion because I really need the help in this case. Thank you so much.
Dr. Shama.
Yes, sir.
Can you hear me?
Yes, sir.
I couldn't recollect what exactly you did for that, something like what called the recto-vaginal or something fistula that was demonstrated, you said somewhere in by radiologists as well as one of your dye study. Catheter went through something.
Yes, sir. It was demonstrated by the radiologist, but I repeated the dye study and there was no demonstrable fistula. And even on the MRU, there was no demonstrable fistula. I think they had just, the dye had just gone into the, while they were doing the procedure, accidentally it must have gone into the anus and they thought that there is a communication, but no communication was found because I confirmed it twice.
Yeah, you also mentioned somewhere during your surgery, some catheter was put somewhere and it came out to the rectum or colon somewhere.
Yeah, not through the rectum, sir. It came out through the urethra. When I opened the uretrocele and then I passed a catheter, it came out through the urethra. Initially, I thought it is coming out through the vagina, but then I confirmed and it came out through the urethra only.
Because there are too many things that happen and it's too difficult to say summarize the case, to understand everything in a short period of presentation. But what I could make out from your presentation, there are 2-3 things, comments about this. If you look at your photographs of the vajagostomy as well as closure of the vajagostomy, the incision is just at the level of suprapubic financial incision level. That is too low site for the vajagostomy. It should be just below the umbilicus. And I don't know exactly what part of the bladder you brought it out. It should be usually say on the inferior side of the posteriorly to the urachus. That is the side one preferably one should try to bring for the vajagostomy. If we get the entry wall of the bladder and for the vajagostomy, invariably the posterior of the vajagostomy usually prolapses out. So that is I don't exactly.
Yes, sir. I had not done the anterior wall. I had done the proper Bloxham's vesicostomy. It was not the anterior wall.
Your location side tells me it was just at the level, incision at the suprapubic level. So to go from
no,
there
sir, that incision was the fenestrial incision I had taken during the this reimplantation procedure. I had closed the vesicostomy incision was about it.
No, even if you see the vajagostomy and the site of the umbilicus, there's a lot of gap available between the umbilicus and the vajagostomy. So that indirectly tells me it is a low place of vajagostomy. It is not properly done on the posterior wall of the posterior wall to distal to the urachus. Was it done on the inferior to the urachus on the posteriorly?
Yes, sir. I had done it on the posterior wall only.
Okay. Now, second point about this is my personal opinion about this. Once you decided, first of all, what is unusual about your case is the thickness of the ureterocele. It was too thick ureterocele to see normally. That you normally see a very thin ureterocele, but occasionally we do see sometimes a thick ureterocele.
Yes,
and those technically sometimes become difficult to puncture the ureterocele.
Yes.
Right. And
yes,
number of times you make a multiple attempts. Unless you're sure that made a multiple punctures here enter in the ureterocele, then there is no point in just making multiple punctures. Unless you make a too close to each other, then they connect to each other. Otherwise, making haphazardly at different places, it can never connect to each other to make a big opening.
Yes, sir.
So that is another point. Third thing, I think once you're convinced the ureterocele was not technically is not done a proper job, means you're not punctured properly, or rather you're convinced that it was not done adequate job. And it was a sequelator, since you already mentioned that.
Yes,
so,
sir.
yeah. So once I decided to open that bladder for vajagostomy, but once I open the bladder, and once you suppose you excise the ureterocele, just the inferior or the intravaginal part of the ureterocele, the mucosal membrane thickness,
yes,
then what was the need to go for the vajagostomy? Since you have already excised the ureterocele, since under your vision that you are doing the surgery under vision, it is not a scopic procedure, where still the sequelator which is projected below the bladder neck into the urethra can still produce obstruction. But since here it is already going to make a wide excision of the intravaginal part of the ureterocele, right? If
yes,
that
sir.
is done, then what is the need to go for the vajagostomy?
Sir, because I thought in spite of
because whenever you do vajagostomy, there's a lot of problems you face about the reimplantation, then maturing the bladder capacity, and the defect in closure. All these things can happen to that. So other alternative, suppose, so my the objection or the suggestion with the two, once you open the bladder, either you go for the excision of the whatever they have done, technical part of the excision of the ureterocele part. And once you excise the large part of the ureterocele, obviously, it is not going to collapse through the bladder neck and produce outlet obstruction. So then there is no need to go for the vajagostomy.
Sir, because there was a right-sided hydroureteronephrosis also, but I thought this ureterocele was compressing, but then
that is purely because already it is producing something like a bladder outlet obstruction because of sequelator. And once you excise that wall intravasically, then obviously it is not going to further from the intravascular, the outlet obstruction. So technically it was just a secondary effect because of the sequelator producing the obstruction of the bladder neck because of the prolapsing ureterocele. And so once you excise that intravascular part of the wall of the ureterocele, then there is no need to go for the vajagostomy. That is my feeling, because once you reduce excise the ureterocele, then it is not going to obstruct the urethra. So this is obviously not going to produce the obstruction on the right side of the ureter. It was just secondary effect because of the outlet obstruction. Or second thing, probably, if you recollect what we did last time, one of our case, Dr. Davendra Tade presented, again, second, third attempt of the puncturing the ureterocele, and there was a deterioration of function of the that side of the moiety or that side of the kidney. It was a duplex basically, but eventually then we did an end ureterostomy. By doing ureterostomy, the same thing what happens. First of all, the ureterocele cannot get refilled, right? So if the ureterocele cannot get refilled, the bladder remains in circulation, or the properly widening or anything is normal. So obviously there cannot be outlet obstruction. So the right kidney, right ureter, and the bladder will grow as like a normal bladder. And there's a left end ureterostomach, and give a chance for the whatever for a year or so, and wait for that. So you can avoid all this whatever has happened because of the whatever.
There was a delayed clearing on the right side more than the left side. So I thought that in spite of the ureterocele getting collapsed, the right side was not decompressing, and then there was bilateral torches. So I thought
that is purely because of the outlet obstruction of the bladder neck, right? There was never been evidence to say there is a obstructed megaureter on the right side. The obstructed megaureter because of intrinsic obstruction of the lower end of ureter.
No, there was no intrinsic obstruction, but then there was quite a delayed.
So it is basically outlet obstruction because of security. Once you intravascularly excise the security, there is no need to go for any other further surgery. Anyway, that is my suggestion. Anybody can make a comment on this.
No, that time I had discussed this case with Ravi Kumar sir, and he suggested that better to go for a vesicostomy in this patient because this child may end up with recurrent urosepsis, and this was quite a thick walled ureterocele, though it was excised, but then the right-sided hydronephrosis was much more and delayed clearance. So I thought in such case better to do a vesicostomy and then assess.
Sorry to say, I mean, just giving us some extras. I will do respect Dr. Ravi Kumar is one of the senior person, but eventually what you have to understand is the pathophysiology and the mechanism of the pathology of the security. And even the thick wall is excised, since it is not a cystoscopy puncture, it was an open surgery. And there is not a question about that you cannot excise the, especially intravascular part of the thick ureterocele. You have to go to the lumen of the ureterocele. Once you excise that lumen, that means, I mean, you reach the lumen, you reach the lumen. That means you reduce the obstruction at least of the left ureter. And once you excise the ureterocele, obviously it's not going to prolapse to the bladder neck. So there's no question of producing secondary obstruction on the right ureter.
Yeah, I have one question. Is there any tips or any precaution to be taken while excising ureterocele at the bladder neck? That is the seco-ureterocele that extended into the bladder neck.
When you basically the problem comes with a puncturing the seco-ureterocele. So when you puncture the seco-ureterocele, we should never try to just make a small cut at the intravascularly. You should also make a cut within the prolapsed ureterocele. Then only that cannot bulge within the urethra. So we also should make a proper puncture within the bladder, which you normally do it for the rest of the ureterocele. But here also in these cases of seco-ureterocele, you should also make a puncture cut within the intra-urethral part, so that whatever the remaining part of the urethra or the seco-ureterocele should not bulge within the posterior urethra to produce a bladder outlet obstruction. So technically you have to make two good punctures, intravascular as well as the within the urethra.
I just have to add to Dr. Mani, okay, as long as you are doing the puncture, it is quite okay. But if you open the bladder to excise or operate on the seco, it is one of the most difficult surgery to do. You note, whenever you remove it, either you remove it incompletely, then it doesn't serve any purpose. If you remove it, it leaves behind a very weakened bladder, and always you have to do bladder reconstruction, bilateral ureteric reimplantation. That is the only reason why we do the puncture. If you want to do surgery, you have to be ready for both proper bladder reconstruction and the reimplantation. I think I will agree with Dr. Mani over there. What is your comment? It is the removal of the ureterocele open and bilateral reimplantation is one of the difficult surgery to do whenever I have done.
Dr. Gurusev has something to say. Yes.
Yeah, see, in all that discussion and criticism, I think the main question which Shama had put forward remains unanswered. So I think I'll rather answer that. See, Shama, the patient has had a vesicostomy, he's had a ureteric reimplant done on open bladder. There are going to be altered bladder dynamics. So I think further from here, the first thing you should do is get a urodynamics done, and then start, pharmacotherapy depending upon what it tells you. And if it is still a very unstable bladder, despite all the pharmacotherapy being utilized, I think you will have to go in for a vesicostomy. That's my thought.
My plan is already to do a urodynamic study, but since she had a vesicostomy, unless I closed the vesicostomy, I couldn't have gone further.
Agreed.
So the plan is for urodynamic study. She is on oxybutynin because her bladder was quite trabeculated. And further, I'll decide on the urodynamic study what is to be done.
Yeah, I think till then, just leave the vesicostomy as it is.
I think to save his kidney function, if he doesn't require CIC, you may have to think of mitrophenol and maybe augmentation later.
Thank you. Can we move on to the next case? Is it me now?
Yes,
Shama?
sir. Yes,
Okay.
sir.
Okay, I'll just start my screen sharing. Okay, now I'm going to present on very interesting finding. I've had about 3 or 4 such cases, and would love to hear other people's experience also. So Atharva, when I first saw him, was 1 month of age with an antenatally detected severe right hydronephrosis with a very large anterior posterior pelvic diameter of 29 millimeters. Left was normal. Parenchymal thickness was down to 5. His EC scan showed that the right kidney function was 35% and obstructed. And so obviously there was nothing else to do besides Anderson-Hines pyeloplasty, which I did when he was 1 month of age, stentless, and the post-operatively everything was fine. Usually I give chemoprophylaxis for a few months, and since the child was quite fine, it was omitted over a period of time. Down the line, he developed phimosis, for which he needed a circumcision, but that is unrelated to the case. Kept following up the patient. By the time the patient was about a year of age, the postoperative, I got his investigations done. The postoperative finding showed that the APD was 20 and the parenchymal thickness had increased to 6. And this EC scan, which preoperatively was 35, it was now showing that it was that it had increased to 45 and it was not obstructed. So that means a very successful repair, but I kept following up the patient to see what is exactly happening. And so preoperatively, now this at the age of 6 years, the patient's APD was 13 and PT was 8, which was like pretty much within normal limits for that particular child. And EC was therefore not needed. Patient was clinically well, urine remained sterile, even at the age of 7 years. At the age of 8 years, the patient suddenly came with a red flag to me that the APD, which was 13, APD which had reduced, had gone up to 13, and the parenchymal thickness had reduced also. So I think there's a mistake here. But anyway, so EC scan showed that the immediate post-op, which was 45, it was still 48 and it was non-obstructed. So obviously the question was what to do, just wait for the patient's APD to settle. So conservative line of management was done. Another year later, again a reassessment was done. By the time this patient's APD had gone up to 31 and the parenchymal thickness had again reduced to 7. And the EC scan showed that the function was now down to 25% and the kidney was showing an obstructive curve. So obviously something needed to be done. And so I decided to operate. Now the usual salvage procedure for any pyeloplasty for us has been endopylotomy. And it was planned by the URS route. Now just to go in a little bit of detail, the endopylotomy can be done either by the cystoscopic route, like this first case, which I was doing using this Kirpeker endopylotome. So you pass in a guide wire from below and then do a percutaneous nephrostomy puncture, retrieve the guide wire. So you have a continuous guide wire from the urethra up till the bladder. Now watch the lip. This lip is so easy to maneuver. So there's no actual obstruction per se, but there was a lip of or shelf of tissue which was falling and closing that PU junction. So usual endopalatomy done, the surrounding fat was seen, and stent was placed, and a DJ stent which was removed 8 weeks later. But this is not regarding this case. Here the the ureteroscopic approach was planned. This is how the ureteroscopy approach is. Of course, this is an earlier patient. And here we can use a holmium laser and cut that posteriorly and fasten a stent and come out. In this particular patient, we planned the ureteroscopic route. So did a cystoscopy and passed a guide wire into the kidney, which went in very easily. And then a 7.5 ureteroscope simply walked into the kidney. So there was no stricture, no angulation. So I thought maybe there might have been some infection or some degree of trauma or something which had led to a temporary hydronephrosis. So relative to the counsel, and the DJ stent was kept, which I removed after 8 weeks. But patient was warned that we still need to follow. So 1 month later, after the removal of stent, there was only mild hydronephrosis, and the EC scan repeated showed that the function had gone up from 25% to 32%, and it was again not obstructed. Another 8 months went by, got a repeat investigation done, and the ultrasound showed that there was ballooning of the upper calyx. Now this was a kind of a warning sign for me. So I got an EC scan done, which again showed that the right kidney function, although it was 32%, but it was obstructed. So now whether to do what to do, I thought it's best to get an antegrade study, because we are having kind of a dichotomy between a retrograde study and an antegrade study. So I got an antegrade pilostomogram done, and you can see this is a highly ballooned up kidney, and there is absolutely no dye. And this is a funnel shape which was of the previous pyeloplasty, but absolutely no dye was going down into the ureter. So obviously it was some kind of a dynamic obstruction, but it was a significant obstruction. So something had to be done. So instead of now planning an endopalatomy, I thought it is better to do a redo pyeloplasty and see, open and see. Well, on opening, there was absolutely no mechanical narrowing. Surrounding fibrosis, which was there, was just cut free, and a Foley's YV-plasty was done. A stent was kept, and after 6 weeks, the stent was removed, and patient remained fine. Now, to show you what exactly was done, so one part was that the previous pelvis, which was reduced in the first surgery, okay, you can see that it like virtually makes the entire pelvis and intrarenal pelvis after the first reduction. This funnel-shaped neourethra of the previous surgery can dilate and produce a kind of a shelf, which then goes and obstructs the pelviureteric junction at the onset of peristalsis. This is what I feel. But from this, it also might be making a case that a lesser aggressive pelvic reduction might be better so that you retain some degree of extrarenal pelvis. And that will help in case of future PUJ obstruction develops, that kidney function will still remain preserved. And that is what we do in laparoscopic pyeloplasties also. So this is how the Foley's YV-plasty was done, that a Y-shaped incision was taken, the single limb going out of the ureter, which was then converted into a V. So you can see that this was a widening of this thing of the pelviureteric junction. And this, because of that, this lip also disappeared. Now, this is a completed Foley's YV-plasty, not a very clear picture. So the discussion which I want to initiate is a long-term follow-up needed after a pyeloplasty. That's one. And secondly, should we avoid pelvis reduction, or at least a radical pelvis reduction? And is this shelf-like recurrent PUJ amenable to an endopylotomy? So to answer a few of these questions, some like Ansari had done this study, and at 3 months, if he says that after pyeloplasty, if the USG and diuretic venogram show a non-obstructive pattern, no further follow-up of a pyeloplasty is needed. A similar study was done, and they questioned whether a pyeloplasty should be followed up more than 12 months. And finally, they recommended that if there is persisting dilatation at the end of 1 year, then you should continue that follow-up with ultrasound even beyond 12 years. Now, from my experience of 3 or 4 cases, I think might be more, I don't completely remember, I didn't have time to check, but this is probably 3rd or 4th case where a recurrence was seen, and with exactly the shelf-like pathological anatomy in the long-term follow-up. The belief I have is that no child should ever need a nephrectomy after a kidney has been successfully salvaged. So I would recommend that you should have a close follow-up for the first 2 years. Then after that, at least one annual follow-up after a pyeloplasty, especially during the phases of growth spurts when the demand of the kidney increases immensely. Thank you. So,
Dr. Smith, good presentation as case collection, rather the keeping the record properly. That indicates how is important to maintain the record. Now your point about making intravesical or the intrarenal pelvis.
Yeah.
See, anytime when you do say in open surgery, obviously we can do maximum reduction of the renal pelvis than probably what we can do it in a laparoscopic surgery.
Yes.
Right. But as you know it, when you reduce the pelvis, we always make a point that we don't open anywhere near the calyceal opening sinuses within the pelvis. That we always check it. So inversely, it is about maybe at least 1.5 to 2 centimeter away from the renal sinus. Away from that, you make a small opening, suck the urine out, see under vision, then go on reducing the pelvis. Right?
Yeah. Yeah.
Now, obviously, in a classical modified under-sinus pyeloplasty, there is always a lip, lower lip of the inferior aspect of the pelvis, which goes within the spatulated ureter.
Yeah.
So I don't, understand how this can be really explained about the formation of whatever some cells-like thing or some mechanism by which it can produce the obstruction. That is one. Second, I don't know exactly.
Can I answer that, sir? Yeah. So
I have no explanation about the cases how this has happened. That anyway, you can make a comment.
Yeah. So first point, the classic teaching which we have learned in JJ from you and from Kirtana madam is the modified Anderson's is classical, and if you see the postoperative result, that is showing that it's well away from the upper calyx. As far as the lower calyx is concerned, it is about 1 centimeter away. So, and when you, in the follow-up picture, if you see in the antegrade pyelogram, there's a vertical kind of look, and that actually shows you that the reduction where it was done, that part has not expanded. But then that also means that the brunt of the increased force within the urinary force within the pelvis, that was borne by the kidney parenchyma itself. So that was the point. And actually, I have not shown the RGU film. I think Gursev asked whether an RGP would be better. Well, RGP was done, and that showed exactly the same finding. On retrograde, there was absolutely good filling of the pelvic-ureteric junction. In any case, we did a URS, and the ureteroscope just walked into the kidney, including like putting it besides the guide wire. So from below, there was no obstruction, but you saw the antegrade pyelostomogram, and that showed the beautiful, demonstrated the obstruction very classically.
Sometimes, Dr. Dasmith, in some of these large hydronephrosis, even your technical thing like a repair, whichever way you do it, comes out very well. And in spite of that, if you'd like to use case, suppose your ureteroscope could walk it easily across the repaired PUJ.
Yeah.
Probably I would not have done anything for that child. Because
that's what we did. That's what we did the first time.
Probably such a
it
good,
didn't work. It lasted a year.
Yes. Now
it lasted 1 year, but the obstruction came back.
Yes, these are the cases specifically. Large hydronephrosis, especially the renal part, which is the inferior aspect, lower pole and middle pole. When they dilate too much, and the pelvis PU junction repair is somewhere near the mid of the kidney level. Now these don't drain so well, and these cases are better, man. Especially suppose if I see a child with a huge hydronephrosis with thin rod parenchyma, probably I will not do for him a classical Anderson's pyeloplasty. I might direct because they are known to may not function so well when you even if you have done a proper job.
Yeah.
Especially, probably I find that is some explanation about your cases. I don't know exactly.
No, sir. Unfortunately, it doesn't explain. With the parenchyma, the lower parenchyma was very, very thick. So ureterocalicostomy was one of the options which I had thought of, but that was just not possible to do. I mean, I would have had to chop off the lower pole and then do an anastomosis, which I don't think was really justified. And then if you see the anterior posterior diameter, it progressively went on increasing till about 7 years. There was absolutely no problem. Once the 8th year onwards, when his growth spurt happened, that is the time when all this has started presenting. And this happened with 3 other cases, which I remember. 2 I definitely remember. Third case I can't seem to recollect that. But exactly the same age this happened. So it is certainly related to the growth spurt, that when the demand of the kidney increases, the kidney is not able to keep pace.
If that is so, probably this is one of the common conditions that we operate in a pediatric urology or pediatric surgery group. And such a large number of cases are operated. Even if you have not done a proper follow-up for a long time, probably some of these cases, say at least what I do is after 6 months, and I repeat a sonography and repeat a PC renal scan, which shows non-obstructive curve, improved function. Or your function may not be significantly improved, but at least there is no obstructive curve. And reduction the size of the APD of the pelvis. Then probably I may not repeat anything for this child, unless child is symptomatic subsequently. And so that means even if suppose if you are not doing this, say follow for these patients, some of these patients, as per your theory, suppose they have got this problem because of which they can get a recurrence. Now there should be a good number of cases. Now suppose your own cases, suppose series of whatever the number, out of which suppose 4 cases you have got that.
No, it's not. Yeah, it's not very common, but it just underlines one fact. Supposing if I had not picked up that this patient was getting obstructed at a later date, then what would have happened? He would have come to me with the function 0 and or badly infected kidney, which may not have been salvageable. My only point is that should we have a change of protocol where, you know, earlier we used to say, okay, fine, if for 2 years if there's no problem, no need to follow up that patient at all. But I think at least one annual ultrasound is essential. This must be out of 200 to 250 cases, I think, of pyeloplasty, that just 4 of them have actually faced this problem. But I mean, stricture is a different matter altogether. I'm not talking about that. I'm just talking about this particular phenomenon. So just from this particular phenomenon, I think it's a good idea to at least do an annual ultrasound, if nothing else.
Dr. Bharti Kulkarni madam has some comment to say.
Dasmit, did you say that you did stentless anastomosis?
Yeah.
I think that may be causing the problem. The stent keeps the thing in place rather than kinking it.
Yeah, but 4 cases out of about 250 is not enough. I mean, I have had my share of problems in those patients where the post-obstructive diuresis is extremely high. But generally, I mean, the perinephric is quite sufficient.
I mean, retrospectively, I agree with Madam Bharti Kulkarni, because I mean, most of us, when you put a stent across and we don't see such a problem happening, rather that what I was trying to say in my previous comment, probably even once you do one follow-up after 6 months or 1 year, and their kidney function is improving well, there is no increase in APD diameter, probably we don't do any further follow-up. Now, suppose this is going to happen, what is your theory behind that? Then probably there must be few number of cases. Probably
I have
gone to someone or that.
Yeah, I have had a few
in different literature.
Yeah, I have had a few discussions with our adult urology colleagues who have found such cases. There's a patient operated in the neonatal period or in the infancy, and the patient has presented hydronephrosis to them at a later date.
I mean, similar. I don't think. I mean, literature search. What does it say? Does it there a good number? I'm not talking about the classical strictures following, which happens.
No, that's what yeah. Stricture is a very. I mean, it's a known phenomenon. This kind of a thing is not a very commonly known phenomenon.
Shall we proceed with the next case, please?
Yeah, please.
Abhilasha is presenting next.
Yes. Just share my screen. Can you see my screen? Can you see my screen, please?
Abhilasha, your screen is not.
Can you see my
we
screen?
can see the screen, but your presentation is not seen.
Okay, just a minute. I'll try it again.
We can hear you.
Okay.
Yeah, is your presentation minimized on your screen?
Okay. Yes, yes, it is minimized.
Okay.
Yes, now.
Yeah, now we can see it. Yeah.
Yep.
Yes. So, good evening, everybody. Although urology cases are interesting, I have a slightly different set of cases that I'm going to present now. So the first case that I'll be presenting is a newborn who presented with a left-sided diaphragmatic hernia. This was a term baby born by emergency section to a 21-year-old primary gravida. Birth weight was 2.15 kg. The parents did have a third trimester ultrasound, although, which said had diagnosed the CDH with the stomach and bowel in the thoracic cavity. There was some restricted fetal growth. So they had come to us in the last trimester and had a little bit of antenatal counseling as to the further plan.
Abhilasha, make it into the
in the
slide
delivery
mode.
I have put in a slideshow.
Okay.
It's not showing you the whole screen?
It is not a slideshow.
It's not in the slideshow.
It's not a slideshow.
Okay. Not yet?
No, not yet.
No.
Surprising.
You did click on that,
Pressing
but
the
it didn't go into
slideshow.
slideshow.
Still not?
No.
I don't know why it's happening.
And you can continue.
Anyway, carry on with what you are talking, because
Can you see something? I mean, although it's
we
minimized?
can see slide number 2.
Yes. Okay. So the baby was in the delivery room, had a weak cry, had respiratory distress. He was intubated in the delivery room and shifted to the NICU. So apart from general support, the baby initially needed conventional ventilation, but had to be shifted to high frequency ventilation because of high pulmonary pressures. Was started on inotropic support. Pulmonary hypertension was managed with milrinone, sildenafil, and oral drug called bosentan. The echocardiography was done, which showed a very high pulmonary pressure. The right ventricle systolic pressure was 70 mmHg. So more than 35 is abnormal. This baby had a right ventricular systolic pressure of 70 mm of Hg. And the baby, in addition, was found to have a large PDA of size 7 millimeter, which was probably contributing to the pulmonary hypertension. So it was.
Can I interrupt you? Because we can see your further slides.
You'll have to click on the left side on your
No,
3,
either
4
click
like
on
that. You'll have to
F5.
click on that.
Either you click on F5 or go back again and rejoin the screen.
Okay. Okay, I'll try that. I'll.
You click on your
sharing and then I'll
side.
share again.
Minimize your presentation and restart it. It will work.
Okay.
Do it again.
Any difference? Has it made a difference?
The presentation is not
Has it
seen.
made a difference?
No, the presentation is not seen.
Okay. I don't know. Okay. Should I share the entire screen then?
Yes, you can, Abhilasha. I think that will make a difference.
Yeah.
Anything now?
Yeah.
or
Now
it's
go to
still the same?
slideshow. Yeah. Now it's come. Go to slideshow.
I am in slideshow.
Okay, then
I am
then
in
just
slideshow.
click on the boxes on the left side, which are saying 1, 2, 3, 4, 5. So for slide change, just go on
No, I
clicking on
can't
that.
see the boxes on my screen. I
Oh.
can't see
No,
my
no.
boxes. I am in full
We can
screen
see
mode.
because that's
It
your
is not
screen.
done
What you're seeing.
properly. This is not done properly. Just again go back. You unscreen your this thing, share screen, and again share screen. Do it again, because this is you see only your again the slides only. You don't see the full screen.
Okay. I think I'll share my entire screen and then I'll go full screen. Let me see if that works. No, it's not letting me share the entire screen.
You get option of the sharing desktop and all this, you know. So you do the desktop.
I'm getting the options of entire screen, window, and Chrome tab. So,
if it is small file, send it to someone else. They can play for you.
okay.
Let someone present and let us do it again afterwards.
Okay. One last attempt, and any difference?
No.
We are seeing your slide 4.
I think then somebody else can.
Yeah, you email it to somebody and let them play.
I'll quickly email it to somebody.
Yeah,
Send it to
next
me.
person
I'll
can
do that.
present.
Send it to me.
And the next person,
All right.
whoever is, can
Yeah.
present meanwhile.
Abhilasha, can you stop screen share?
Yes. I have stopped.
Yes, it is stopped.
Okay.
Who is the next person who is supposed to present?
Sir, I'm presenting.
Okay.
Is my screen visible?
Yes.
Just 1 sec. Mm. Is this visible?
Shama, your slides are not visible. I can see your name.
Okay, just 1 sec. Are the slides visible now?
No.
Just 1 sec.
Now your slides are visible, Shama.
Okay, sir. Okay, sir. Okay. Good evening, everyone. So today I'm presenting a case of left lung CPAM. So this was a child who was 4.5 months female, antenatally diagnosed left lung congenital pulmonary airway malformation. The child was otherwise asymptomatic. CT scan was done. The child was born outside of Pune, and then a CT scan was done on day 2 of life. And a 2D echo was also done, which showed a PDA and PFO. So this was the CT scan which was done on day 2 of life, which showed multiple cystic spaces in the left lung, occupying the upper lobe as well as the lower lobe. So this was quite an extensive CPAM. When she came to me, I just did an X-ray chest and I had advised her to do a CT scan, but in between the child's family and the child developed COVID, and hence the CT was delayed for a month. At 5.5 months, the CT scan was done, and then you can see a huge CPAM, which was occupying the upper lobe as well as the lower lobe, though clear marking was not there, and so this is again the CT scan picture. I'll just run the video for the CT. So this is the view. You can see here it was extending into the apical portion of the left upper lobe, the posterior segment, as well as extending into the lower lobe, quite a huge looking CPAM. But the delineation, whether it was really occupying the upper lobe or lower lobe or both, was not clear from the CT scan. So this is another view. Sorry. So here you can see it is occupying the upper lobe as well as extending up to the lower lobe. So though many of us do thoracoscopy for CPAMs or any thoracic lesion, since this was looking quite a huge lesion, I thought to proceed with a thoracotomy. Just the routine ventilation, double lung ventilation was given, and this is the lateral position for open thoracotomy. On opening posterolaterally, we can I was able to visualize this large cystic structure. So, sorry. So this was a large cystic, I don't have the further pictures, but this was a large cystic lesion with multiple cysts, which was mainly occupying the lower lobe. Though on the CT, it was looking like more of the upper lobe was involved, but only a small part of the upper lobe was involved. And most of the lower, it was involving the lower lobe of the lung rather than the upper lobe. So it was quite a easy resection as such. A non-anatomic resection was done. And this was the video post-excision. There was no bronchopulmonary, there was no leak as such, air leaks, very minimal leak was there, which was closed. And then this is the expansion of the lung post removal of this lesion. So this is the excised specimen and the picture. This is the post-op X-ray after removal of ICD on day 3. The child did quite well post-operatively. And the HPE was suggestive of type 2 congenital pulmonary airway malformation. Though on the CT, it was like a type 1 with large multiple cysts. Thank you. This is a usual case, but just because it was occupying the on the CT, it was looking like it was involving the upper lobe as well as the lower lobe and extensive lesion. I thought to present it. Thank you.
It was not seen on the plain X-ray that we showed on one of the plain X-ray before the COVID. The child
Yes,
X-ray
sir.
that was taken.
Pardon me, sir.
Now, the plain X-ray did not reveal such extensive lesion.
No, that's what X-ray.
X-ray
was not showing anything on the X-ray looked absolutely normal actually. In fact, there was no shift also, in spite of having such a huge lesion.
Right. No, exactly. That's what I'm trying to say. What CT tells you, not necessarily exactly the picture, because most of the time what happens is that we're not able to read that CT plate so well because they're in a different cut sections. But whereas the plain X-ray, of course, that we do, see much better. And the plain X-ray did not reveal any extensive lesion, at least on a producing compression effect on the shift of mediastinum.
Yes, sir. I sat with the radiologist and told him to show. Then he was quite particular. He was saying that it's occupying mainly the upper lobe, but then intraoperatively, what I found was it was occupying the lower lobe rather than the upper lobe. Very small portion of the upper lobe was involved.
Basically, CT was showing more in the lower lobe rather than the upper lobe. But as I said, sometimes we are not able to read the one particular section. You find that the entire chest is seen, so we say it is both the things are involved, but not necessarily because it can be just a cut taken through the one part of that segment of the lung. So that appears as if the entire lung is involved, but that is not true because if you see the plain X-ray, it doesn't reveal similar extensive lesion. So probably for me, maybe for the juniors, I can make a comment on this. Probably the child was, though antenatal diagnosed, I have not really answered the what time one should go in, whether to go in only when they develop a symptom or to go in even otherwise asymptomatic patients. Because this is something the child was absolutely asymptomatic, no breathlessness, no chest infection, never had an admission because of respiratory infection. So whether to really go in so early for this age, I really don't know. And Dr. Bharti Kulkarni, can you make a comment on this?
Shama, please unshare.
Yeah.
Yes, Dr. Abhilash, your screen is that's now. You can go ahead, unless there is someone else presenting.
I'm here. I have shared my presentation with both Dr. Patankar and Dr. Dasmeet Singh. If one of them could please play it.
Somebody has presented. You can see that your slides.
No, I cannot
Hello.
see my own slides now.
No.
Oh,
But on the monitor.
No, you see it on the monitor. You don't share. I've already projected
No,
it.
I'm trying to look at your screen. I cannot see it.
Don't see on my
Your
screen.
screen
You just go on the general screen, home screen of Zoom.
Okay. Okay.
Got it? When you want to change, you just
All
tell
right.
me. I'll change. Yeah.
But how come I can't see your screen then? Everybody else can see it.
You unpin your side. I think you have pinned something, or you have done something. Everybody can see your present.
You go back again and rejoin again, because what has happened, something you must have played there.
Okay, I'll do that as well. I'm so sorry for
Anyway,
this, everybody.
Dr. Mane's question, when to operate? So we will operate probably at the age of 4 to 6 months if they are asymptomatic. The reason being that if they get infected, then if we have to operate, it becomes particularly difficult thoracoscopically and even open. So if they are asymptomatic, we will go ahead and operate at 4 to 6 months.
Yeah, that's our practice also. By about 3 months, we feel that anesthesia is safe, everything is much safer. And that's the time when we'll operate. But only the large ones, the very small ones, we can just wait and watch.
Hello, Dasmeet, can you hear me?
Yeah. Shanko,
Yeah,
go ahead.
yeah. In case if Abhilasha cannot really see this, you continue, I will talk about it. It is just a short presentation about it.
You just have to tell me when to change the slide.
Yeah, you go on changing. I will go on changing.
Okay, I'm back.
Can you see Abhilasha?
I'm back.
Yeah, can you see your slide?
Can you hear me? I can see your screen now. Yes, I can see your screen. Sir.
Okay. So you just tell me when to change. Yeah, go ahead.
Yes, please. I'll go to the next one, please, sir. So this was the case of prenatally diagnosed diaphragmatic hernia, although diagnosed in the last trimester with a left-sided CDH with stomach and bowel in the thoracic cavity. Observed to expected LHR was 28.5% and there was restricted fetal growth. On delivery, in the delivery room, the baby had respiratory distress and was immediately intubated. Next slide, please. So the preoperative management from day of life 1 to day of life 5, apart from general support, baby was initially kept on conventional ventilation, but because he was not having good blood gases and good oxygenation, so he was shifted to high frequency ventilation. For shock and ventricular dysfunction, the baby was started on inotropes, and for pulmonary hypertension, the baby was started on milrinone, stepped up to sildenafil, and then eventually bosentan. Next slide, please. So, next slide, please. So, 2D echo done showed a very high pulmonary pressure. Yes. So, apart from a very high right ventricular systolic pressure, which is a measure of the pulmonary pressure, there was a large PDA of size 7 millimeter with bidirectional shunting. So this was probably what was not letting the pulmonary hypertension come down, because we had already ventilated the patient for 5 days, started all measures for suppressing the pulmonary hypertension, but baby was not settling. So the PDA probably explained the persistent pulmonary hypertension. So we decided to go for PDA ligation along with the surgery for the CH. Normally, in an open diaphragmatic hernia repair, we would have gone for an intra-abdominal, for an abdominal route. But because we were considering PDA ligation for this baby, we decided to go for a left thoracotomy approach. Next slide, please. Next slide. Yes, okay. So On day of life 6, we eventually went in for a left open thoracotomy, repair of CDH. There was a CDH with a sac. So we reduced the contents, closed the defect, which you can see on the image on the left side. And from the same route, the posterior pleura was opened, the PDA was identified, and the PDA was ligated. Next slide, please. Yes, so this is the preoperative and the postoperative chest X-rays showing some expansion of the lung. Next slide. So post ligation of the PDA and the repair of the diaphragmatic hernia, the baby did go into shock again and had what is known as a post-ligation cardiac syndrome. Next slide, please. I'll just tell you a little bit about this syndrome. So after surgical ligation or coil ligation of the PDA, over a period of time, the left ventricle is exposed to an increased afterload, which leads to both systolic impairment, which leads to decreased stroke volume, decreased left ventricular output, and patient goes into shock. In addition to that, there is also diastolic impairment, which leads to increased pulmonary venous pressure and leads to pulmonary edema and decreased compliance. So both these factors will affect your ventilation as well as your circulatory system. So this usually happens in 4 to 12 hours, not in the immediate postoperative period, but maybe about 4 to 12 hours after the surgery. So this is what we encountered. So the management is, of course, inotropes and hydrocortisone in case of progressive or refractory post-ligation cardiac syndrome. So this patient was given steroids apart from the other supportive care, which led to an improvement. Next slide, please. So the course from day 11 to day 20 of life, finally baby was extubated on postoperative day 5 and taken on non-invasive ventilation, tapered to room air by day of life 20, and eventually shifted to, feeds were upgraded, shifted to oral pulmonary vasodilators. Next slide. And in the next 10 days, from day of life 20 to day of life 30, there was further improvement. Breast feeds were established, and patient was finally discharged at 1 month of life on oral supplements and oral sildenafil. So we've been following this patient up. He's about 3 months old now, and so far is doing developmentally okay. Audiology screening has passed, and weight gain is good. And subsequent 2D echo shows a resolution of the pulmonary hypertension. That's all. Any questions on this one, on this presentation?
So, in general, a comment. See, this is surgical ligation, but the same thing can happen in post-op period in newborn, any newborn, where PDA is open, it can get closed. And whenever it closes, the same thing can happen. The kid who is doing otherwise all right suddenly deteriorates, and that is because of the PDA which is getting closed. So one needs to remember that. I think somewhere there are 2 devices open, so there is echo sound. Whoever has 2 devices open should switch off or mute one of the device. I don't know who is that, but there is an echo sound. So it can happen in any post-op patient in NICU.
Okay. Okay, should I move on to the second case then?
Yes,
Yeah.
please.
The second case was hepatic AV malformation in a neonate. Yes. So this was a 39-week gestation male child. Birth weight was 2.3 kg. He was delivered in an outside hospital, and the initial management was in another hospital, not at our institute. So he presented on day of life 3 with severe respiratory distress. He was initially managed as sepsis in view of low platelet count and raised CRP. Next slide, please. Next slide. Yes. So, but because there was no response to IV antibiotics and distress was increasing, leading to a requirement of ventilation on day of life 12, a 2D echo was done outside, which showed pulmonary hypertension and dilated right atrium and ventricle. So considering PPHN, the baby was started on sildenafil. Since there was no improvement even on starting sildenafil, he was further referred to our institute for further management. Now, during the investigation for the causes of pulmonary hypertension, I think the neonatologist was screening the IVC and doing an echo and just went down to the liver, and they found this lesion in the liver. So we got a formal ultrasound of the abdomen with a Doppler, which showed a 4.3 by 3.4 by 4.5 centimeter area of altered echogenicity in segment 7 and 8 of the liver. There were some areas of calcification within it, and there was both arterial and venous flow within it. So we eventually went for a triphasic CT, which showed a similar lesion, which was iso to hypodense on the non-contrast image with some speckled areas of calcification. And on giving contrast, the central area was poorly enhancing, with multiple tortuous vessels seen within the lesion in the arterial phase. Next slide, please. So we got a better picture of the anatomy, of the vascular anatomy, the left hepatic vein, the middle hepatic vein. Right hepatic vein was pushed anteriorly by the lesion, and the hepatic arterial anatomy was noted, the pulmonary venous anatomy was noted. Initially we started the patient on propranolol as well as steroids to see if there would be any response. However, the child did not improve at all. So, and because the coiling and interventional procedures were not feasible, we could not find an interventional radiologist who was comfortable doing a procedure in a neonate of about 2.3 kg. So we decided to go ahead and operate this baby and do a right hepatectomy. Next slide, please. So this was the lesion seen on opening up the abdomen. So we did a standard hepatectomy. The right hepatic artery ligated, the right portal vein was identified and ligated. Next slide, please. And IVC control was taken. We took the hepatic veins intrahepatically. We did not try to ligate the right hepatic vein before we proceeded. So we divided the liver and we took the right hepatic vein intrahepatically. And that was the cut section. Next slide, please. So patient had a dramatic improvement after surgery. Third postoperative day, he was extubated. Hemogram, LFTs started to settle, and patient was discharged on the 10th postoperative day. On sequential 2D echo, the pulmonary hypertension had subsided. Histopath confirmed the arteriovenous malformation, and the patient has been on regular follow-up since nearly 2 years and is doing well. Next slide. So this is a rare entity, a patient who presents with just pulmonary hypertension initially. And of course, this patient also had low platelet count, so he had some evidence of consumptive coagulopathy. So it's usually an incidental finding when you are trying to look for causes of low platelet counts or failure in newborns. So other lesions of the liver with similar presentation would be multifocal or diffuse type of hepatic hemangiomas. Usually the focal single hepatic hemangiomas would not present with such a dramatic presentation. The other diagnosis would be a caposiform hemangioendothelioma, but these are actually now found to be tumors from the retroperitoneum which invade into the liver lesions. And other tumors like mesenchymal hamartomas or hepatoblastomas may occasionally present. Very vascular tumors may present with such findings. Next. About 35% of these lesions or tumors are multifocal or diffuse. So as I said, the focal lesions will not cause such a problem, but these diffuse lesions would have a survival rate of between 60 to 100%. Death is usually due to cardiorespiratory compromise caused by lesions refractory to medical management. Medical options can be diuretics to control the heart failure, propranolol, steroids, and some cases interferon 2 alpha has shown promising results. Limitations of coiling or embolization are the size of the baby, the cost of the procedure, recanalization or slipping of the coils, and it is finally only an interim procedure, because you need to go in and take out the rest of the liver, because sometimes it leads to cholangitis and progressive hepatic dysfunction. So eventually what you need is both coiling as well as hepatic resection. So because the management, the embolization was not feasible in our setup, we decided to go for hepatic resection in the newborn. Thank you. That's all.
Nice presentation, Abhilasha. We have
thank you.
We have encountered such problems wherein I was landed up doing a hepatic arterial ligation, and that's known to help such people also.
Yes.
So did you consider that as an option for this lesion? Because
yes, even that is
coiling was not possible.
Yes. So as I said, that is an option. Even with coiling, you just coil and you leave it. It leads to cholangitis. It leads to progressive hepatic dysfunction because of the liver sitting there without hepatic arterial supply. So you need to get out that segment at some point of time. So even if we go in just ligate hepatic artery.
Yes, we have ligate because it is a benign tumor. You need not worry about it being left alone, and its natural course sometimes is that it regresses after you ligate the hepatic artery.
Yeah, can I say something, Rajiv?
Yes,
the margin of error was very less.
Yes, please.
And the margin of error was very less. Taking chances was, and we were very confident of getting rid of it. So yeah, and we had CUSA, we had everything to do so.
Right,
and,
right.
You know,
how low were the platelets?
Platelets were normal. This was not the problem with the platelets was not there.
No.
70, 80,000 somewhere.
So initially he did have some low. Yes.
Okay.
So he was initially labeled as sepsis.
Right. Good. Right. Anyone else has any comments?
Thank you.
Wonderful. Otherwise, nice presentation, Abhilasha.
I have a question. It's not
so sorry for the confusion in the beginning.
Yeah, Usha, what's your question?
This is related to the pyeloplasty case. If you get a child, newborn baby with a huge mass, almost occupying half of the abdomen, and it's secondary to PUJ, how early we operate this case? This is open to everyone.
At presentation.
At presentation, whenever. In a newborn, probably by about 7 days I had to operate.
I've actually opened this case and then found the ureter was totally atretic up to bladder, nothing to do, and there was a lot of kidney tissue was hardly anything, so couldn't do much for this case. So just did a pylostomy. What different could have been done for this case?
You're the best judge when you operate, but certainly the pelvis itself can be utilized to make a ureter or ureteric replacement. So bowel segment, Montes.
This is just a 5-day-old, 3-day-old baby was there.
Yeah, so I think you've done a good job. So if you've done a pylostomy, so now just wait for the baby to grow up and then do a ureteric replacement at a later date.
Sure. Thank you.
Dr. Vinod Kapoor, I remember Dr. Usha used to use appendix to replace the ureters also.
Yes.
I've seen him do that.
So right side you can use appendix. Left side becomes difficult.
This was a left side case.
Okay. Anyway, so are your cases completed?
Yes, sir, we are done with the cases.
We are done.
Wonderful.
Actually, it's already 10:35. So we have more cases, but I think we should pass it. Keep it for next time.
We had a nice interaction, nice meeting, and I thank all the participants and the members who joined in for this. I think Dr. Devendra has done remarkable work in getting MMC accreditations for this meeting. This is the first meeting to be accredited with 1 point, all due to his Herculean efforts. And this was a meeting which recorded 140 registrations. That is why we had to stream it live on YouTube also. So thank you, Dr. Devendra, for your hard work. So every participant and the speaker would be getting a MMC point within the Maharashtra limits.
Yeah.
So I thank you one and all, Dr. Dasmit, Dr. Shama, Dr. Abhilasha, okay, and
Ashlesha.
Ashlesha, doctor. Yeah, Ashlesha. Yeah, so.
Okay, thank you, everyone.
Thank you.
See you at Varanasi for PESICON, whoever is coming.
Wonderful.
Thank you so much. Okay.
Thanks a lot.
Thank you.
Bye.
Good night.
Good day. Good day.
Yeah, good night.